my name's Anna. I'm the head of the internal medicine department at Davies Veterinary Specialists, and this is my colleague Lara Varron, who's the head of cardiology here at Davies as well. So today we're just going to be talking about a few cardiology topics, primarily dogs and cats with heart murmurs. So Lara, if I was presented with a dog with a heart murmur that didn't have any clinical signs, no coughing, no dyspnea or anything like that, would I consider starting any medications for this patient?
It's a good question because a lot of the time you hear a heart murmur in an asymptomatic patient, you want to be proactive and help that patient. The decision to start medications is going to depend on your species, your disease process, and the stage of that heart disease. So if we think about small breed dogs, because that's our most commonly diagnosed heart condition in small animal practice, we're thinking about mitral valve disease. And so the medication that we would be considering would be pimobendan. Now, we start pimobendan once dogs go from a B1 stage, so murmur but no heart enlargement, to a B2 stage, which is a heart murmur and the presence of cardiac enlargement. We cannot determine based on the grade of the murmur alone whether a dog is a B1 or a B2. And we've seen that from multiple different studies, the more tests that you do on that animal, the more data you have, the more accurate your staging is going to be. Now, the ideal staging test would be an echo, but not every owner can afford that. So other things that you could consider would be a proBNP. If the proBNP is normal, then it's probably less likely to have cardiac enlargement, or a set of thoracic radiographs to look for left atrial enlargement. You can do a vertebral heart score or a left atrial heart score. Because we don't want to start that pimobendan before it's actually due. Pimobendan is generally a very safe medication. There are few, but not zero, situations where starting it will actually harm a patient. But dogs can stay in that asymptomatic phase for years. And pimobendan is a very expensive medication. That could end up costing the clients thousands of dollars over several years of medications that they don't actually need. When we think about our large breed dogs, though, we have to be a little bit cautious because in small breed dogs, the severity of heart murmur roughly correlates with the severity of heart disease. A soft murmur is more likely to be a B1 versus a loud grade 5 or grade 6 murmur is more likely to be a B2. That kind of grade 3, grade 4 in the middle is really challenging and can go either way. With our large breed dogs, their murmurs tend to be softer. And that is a manifestation of both the physiology of disease, but also the size of our patients. It's a lot easier to hear a murmur in a Chihuahua than it is a Great Dane. So sometimes even in dogs that have a grade 1 or grade 2 murmur but are large breed dogs with DCM, they can have very advanced disease. So in those situations, I always recommend doing some further diagnostics like a proBNP, an echo, or a thoracic radiograph to better characterize what stage of heart disease that patient is in.
Okay, and so what about an asymptomatic cat? Are they different? Should we be introducing medications earlier? Do we use pimobendan in cats?
Yeah, that's a good question too. Cats are even more challenging than dogs, right? Because we know that cats can have a heart murmur and have no heart disease. They can have a heart murmur and have heart disease, or they can have no murmur at all and have significant heart disease. So I would never start medication based on just the presence of a murmur in a cat alone. Now, the medication that's been shown to provide benefit in kind of our B2 stage cats would be clopidogrel. That medication we use once there's evidence of heart enlargement to try and reduce the risk of thromboembolism. But again, we need to do some sort of test to determine whether or not the cat it qualifies for that medication. This is another example of when I love using proBNP in general practitioner practices, because if you do a proBNP and that's normal, it doesn't rule out the presence of heart disease altogether, but it at least tells you that there's probably no atrial stretch and that the addition of clopidogrel is not warranted. Now, pimobendan in cats is even trickier. It's a hotly debated topic amongst cardiologists. Most people would not recommend it for an asymptomatic animal. It's not licensed in cats, Some cardiologists do use it after the onset of heart failure, but it would not be indicated in most cats with asymptomatic heart disease. And that's because of the type of heart disease they get. HCM is more of a disease of relaxation rather than a disease of kind of systolic or pumping function.
Okay, so just going back to the clopidogrel comment, so I always thought as a medic, you only gave clopidogrel when there was smoke or evidence of thromboembolic disease. So has that theory changed, or was I wrong? Is that different?
Yeah, if you look at the ACVIM consensus statement, there are some guidelines for when we add that in. Smoke, which is spontaneous echo contrast, that kind of swirling that you can see on echo, or a thrombus, would definitely be an indication for the addition of clopidogrel. But we actually try to add it in a little bit earlier before that, because if we get to that stage, the risk is already pretty high. So one of the risk factors that we think about in cats with HCM is left atrial dimension. And so that's when an echo is really helpful, because we can look at our LA to AO ratio. Anything above 1.6 in a cat, and they qualify for the addition of clopidogrel. And that's to reduce the risk of thromboembolism. We're never going to make that risk zero, but at least we can reduce the risk for that owner and for that cat. And again, if you can't do an echo, or the owner can't refer or can't afford it, that's a great time to do a pro-BNP. If that pro-BNP is very high and you have a cat with a heart murmur, there's a greater chance that that cat has significant heart disease, and clopidogrel might be warranted in that patient.
Okay, that's really interesting, thank you. And what about ACE inhibitors? So historically, in general practice, I might have introduced an ACE inhibitor in either a dog or a cat with a murmur or significant heart disease. So what do you think about ACE inhibitors?
I think ACE inhibitors play an important role in the treatment of heart failure. Whether or not we use those in asymptomatic patients, the kind of consensus has shifted a little bit in recent years, and it's really different for each of our species and each of our diseases. In our mitral valve dogs, there have been a couple studies that have come out recently that haven't really shown a significant benefit of adding that in when they're in B1 or B2 stages. I think we all as cardiologists agree, after the onset of heart failure, when you have, when you're giving diuretics, when you've got massive kind of RAS activation, there's a very strong role for ACE inhibitors in those patients. But before, I think the evidence is less convincing. And so many cardiologists in stage B2 mitral valve dogs only add in pimobendan. They don't add in ACE inhibitors. It's another expensive medication, and it's not completely benign. Most dogs tolerate it fine, but it can affect kidney values, and it does require a little bit more monitoring than pimobendan alone. That's a little bit different for our DCM dogs, in which I think the evidence in the asymptomatic patient is stronger. So for me personally, if I have a dog with systolic dysfunction, heart enlargement, and I'm putting them on pimobendan for DCM, I do add in an ACE inhibitor at that point. Cats, again, cats are tricky. They just, they're always just a little bit more challenging. Most cardiologists do not recommend the addition of ACE inhibitors for asymptomatic cats. And then even after the onset of heart failure in cats, some clinicians use an ACE inhibitor, some clinicians use spironolactone, some use both. But I think at that stage we have a little bit more evidence again for RAS activation. But in an asymptomatic cat, I would never reach for an ACE inhibitor or a joint product like that. And one thing to keep in mind for ACE inhibitors is I think of these as kind of a long-term or a big picture medication. We use them for RAS suppression, but also to kind of reduce remodeling, reduce fibrosis within the heart muscle itself. They are not going to provide symptomatic benefit for our patient. So if you do have a patient that's showing exercise intolerance, or that you're concerned is on the verge of failure and you want to kind of help them in some way, adding in an ACE inhibitor is not going to make that patient feel better. It's just kind of looking at the big picture. Can I slow down remodeling within that left ventricle?
Okay. So we've focused quite a lot on asymptomatic patients. So what about a patient that I might class to be symptomatic? So a dog, maybe a 10-year-old Yorkshire Terrier, for example, that was presenting and has a grade 4 murmur, for example, but is now coughing, and I'm worried, and the owner's presenting the dog to me for a cough. Is that a patient that I might be more proactive in and introduce other medications for example, if it's coughing?
It's a good question. I think we need to think about why that patient is coughing. There's a really good paper that was published in the Journal of Small Animal Practice by Chris Linney and Luca Farrison, and it's on the cardiac cough in dogs. And I would encourage anybody to read it if you have an interest in this subject. So I think for a long time the dogma was, if an animal with heart disease is coughing, it means it must be in failure. And that's from pulmonary edema. And when we actually investigate that a little bit further, most of the time we don't think that that's the case. Often the cough that we deem cardiac is actually from left atrial enlargement, left-sided heart enlargement, and physical compression of the mainstem bronchi by that large left atrium. So it's kind of more of a physical insult to the bronchi rather than pulmonary edema. You don't actually have any cough receptors in your alveoli, so if you have mild pulmonary edema, that shouldn't induce a cough on its own. So what does that mean? Well, it means that a patient with advanced B2 heart disease with a big left atrium in the absence of heart failure might have a chronic cardiac cough. The only way that we can make that cough better would be to shrink the heart, which unfortunately, unless we're referring that patient for mitral valve repair surgery, we're not going to be able to do. So most of the time, in those patients, I treat them symptomatically with cough suppression, maybe codeine, just to keep them a little bit more comfortable. But if you have a patient with a loud murmur and a chronic cough, that may be more evidence that they do have left atrial enlargement. So all the more reason to either do a heart scan, take a chest x-ray, or do a pro-BNP to make sure that you're not missing underlying heart disease. But I think, again, it's important to remember that a cough and a heart murmur does not necessarily mean heart failure. I think one thing to keep in mind is that oftentimes we can have cough for many other reasons besides heart disease. And if we think about kind of the patients that have cough and that have heart murmurs, a lot of those patients are similar breed, similar age. So, I mean, if you had a patient that came in for coughing in maybe an old Yorkie, as you were talking about, what would be on your differential list in terms of medical causes of cough?
Well, in an older patient, I guess the typical one, in particular a small breed dog, would be chronic bronchial disease. And we would obviously need to do a medical workup to investigate that. In a Yorkshire Terrier, we might consider tracheal collapse, for example, to be contributing as well. And then, of course, there's other age-related diseases, or we see more commonly in older dogs, for example, neoplasia and that sort of thing. So in these dogs, we tend to work together to find out sort of what stage cardiac disease they might be in and whether they're suitable to be sedated for radiographs. And I think radiographs are really important for this population of dogs because it can help differentiate between a respiratory cause of a cough and a cardiac cause of a cough due to left atrial enlargement rather than cardiac failure. And some of these patients will also have evidence of heart failure, but that wouldn't necessarily be causing the cough.
I was going to add to your point that yes, dogs with heart failure can cough, and sometimes their cough will get worse when they're in failure. Again, mostly because of an acute enlargement of their left atrium. But what's really important to remember is that if a dog has heart failure, classically, the most consistent signs of heart failure in a patient are increased breathing rate and increased breathing effort. So if you have a dog with a cough in the absence of those clinical signs, even if it has a heart murmur, I would be less suspicious of pulmonary edema or heart failure in that patient.
So why then, in those patients that don't have signs of dyspnea or tachypnea and that sort of thing, sometimes those patients do tend to improve on furosemide. So why is that if they don't have evidence of pulmonary edema?
Yeah, There are a couple different reasons. One is if we think it's a cardiac cause of cough. So if we think that the left atrium is big, then giving furosemide will essentially lower our left atrial pressure. That's how that medication works. That's why it works in heart failure. So in some dogs that have a really big left atrium, if we give them a little bit of diuretic, their left atrium will shrink ever so slightly, just take a little bit of pressure off of those mainstem bronchi and improve their cough. Now, I don't think that that's the best course of action for those patients because furosemide is definitely not a benign medication, especially in a geriatric patient, which most of our patients are with this heart disease. So we can cause azotemia, we can cause dehydration, electrolyte derangements. And oftentimes dogs will have a cardiac cough, potentially for years prior to the onset of heart failure. And that's years that we could maybe spare them the diuretic dose before they actually need it. One of the other reasons that dogs can cough, or dogs can improve in terms of their cough because of furosemide is that it does have some other effects on the lungs. And there are reports of it kind of causing bronchodilation. So sometimes you'll have a dog that has no heart disease whatsoever. Somebody tries a course or a trial of furosemide for a chronic cough, and you do see some minor improvement in that patient. But often they still cough. That's short-lived. It's not as much an improvement as you would like. And importantly, you're not really treating the underlying issue. So it's better to find out why that patient is coughing and address that rather than give it a medication that is not completely benign that could have side effects.
Yeah, and certainly as a medic, we do see a number of those patients coming through that have received furosemide and are subsequently azotemic or have electrolyte derangements, and then it's quite difficult to manage that in a patient with concurrent cardiac disease. So it's really important, isn't it, to try and find out why they're coughing in the first place.
Yeah. And it's important to remember that we would only really expect a cardiac cough in patients with, again, advanced heart disease. So if you have a small breed dog and you don't hear a heart murmur, or you hear a very soft heart murmur and that patient has a chronic cough, that's much, much more likely to be non-cardiac in nature and should maybe come see Anna rather than come see me.
And then I'll ask Lara to scan, to scan the dog for me.
Exactly.
Super, that's been really interesting. Thank you so much, Lara. That's really, really helpful. And I hope that's also helped our general practitioners out there as well. Thank you.